Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, the CNS demyelinative disorders. The CNS demyelinative disorders demystified. Myelin sheath is actually the covering of the axons. So we have myelin sheath of the central nervous system and myelin sheath of the peripheral nervous system. The myelin sheath of the central nervous system is formed by oligodendrocyte and the myelin sheath of the peripheral nerve is formed by the Schwann cells. To understand and to approach demyelinating disorders, an important concept has to be understood. Dysmyelinating disorders and demyelinative disorders. Dysmyelinative disorders are those disorders wherein the myelin sheath is not formed in the first place. The myelin sheath is not formed in the first place due to biochemical abnormalities, example metachromatic leukodystrophy. Whereas in a demyelinative disorder, the myelin sheath is formed, but then due to some acquired disorders, the myelin sheath gets damaged. So myelin sheath is formed, but later it gets damaged. These are known as demyelinating disorders. Classic example is multiple sclerosis and ADEM. Right. Now let's see all the demyelinative disorders and selected dysmyelinative disorders. The demyelinative disorders, of course, the disease which comes to the forefront is multiple sclerosis. Multiple sclerosis is a demyelinative disorder of the central nervous system, wherein the myelination of the central nervous system is formed by the oligodendrocytes. So, multiple sclerosis is basically presumed to be of an interaction between the environmental, genetic, and immunological dysregulation. The environmental being basically a vitamin D deficiency. So vitamin D deficiency is presumed to be one of the important environmental reasons, the others being genetic and immune dysregulation. This is a demyelinative disorder. Obviously, the parts which are well myelinated gets involved. For example, if we take the sensory tracts, the spinothalamic tract is least myelinated and therefore multiple sclerosis does not affect the spinothalamic tract. That means pain and temperature are spared. The posterior column is well myelinated, so it affects the posterior column. It causes the demyelination of the posterior column, so persons will have the touch, position, joint, vibration sense getting affected. Likewise, the corticospinal tract is well myelinated and therefore the myelin sheath gets affected, so they'll have features of severe weakness. An important point is that a demyelinative disorder will present with almost sudden onset of weakness, sudden onset of focal neurological deficit. If a person has got focal neurological deficits, there are only two possibilities. One, vascular, like cerebrovascular accident. Second is the demyelinative disease. Why do the demyelinative disease present suddenly? Because the myelin sheath, when it covers the axons, the sodium channels are present at the nodes or the internodes. So an impulse can jump from one internode to the other internode like a kangaroo, which is called as saltatory conduction. So it goes very fast and at a very tremendous speed if there is myelin sheath, if it is intact. But the moment the myelin sheath is lost, the sodium channels get redistributed over the axons and the conduction becomes slow. Because the conduction velocity is suddenly affected, persons will develop sudden neurological deficit. So if a person develops a neurological deficit which is of sudden onset, basically there are two possibilities. One, vascular, second, demyelinative. So coming back to the parts involved, it affects the posterior column which is well myelinated, it affects the corticospinal tract which is well myelinated, it affects the optic nerve. Optic nerve is also well myelinated, so when the optic nerve gets affected, it cannot carry the afferent impulses when the light is shown. So they will develop a very classic sign which is known as the relative afferent pupillary defect. So once we throw the light on the normal pupil, it begins to contract. Suppose the right optic nerve is affected. When we throw the light from left side to the right side now, because of throwing the light on the left side, both the pupils constrict, and then when we come to the right and when we throw the light, now instead of constricting, this is in a phase of dilatation because of the light thrown previously on the normal left eye. So it is in a state of dilatation. It does not constrict because there's a optic nerve involvement. So this is known as relative afferent pupillary defect. So normal pupil constrict, but the pupil which is affected because of the optic nerve involvement, instead of constriction, there may be even a relative dilatation of the pupil because of the constriction of the consensual light reflex. So relative afferent pupillary defect is very characteristic of optic nerve involvement. Optic nerve is a well myelinated nerve, and therefore the optic nerve gets affected. Eighth nerve is a well myelinated nerve, therefore eighth nerve gets affected. The corticospinal tract gets affected, so they'll have a sudden focal neurological deficit because of the decrease in saltatory conduction. They have a sudden deficit. The posterior column gets affected, and therefore when the posterior column gets affected, especially in the cervical cord, they develop a characteristic symptom known as Lehermet symptom. When we ask them to flex the neck like this, they have electric shock sensations going down the spine because of the posterior column involvement. The cerebellum gets affected, so they'll have features of cerebellar involvement in the form of vertigo or ataxia. The medial longitudinal fasciculus gets affected. Medial longitudinal fasciculus is the connecting tract between the 3rd, 4th, 6th and 8th nerves. And predominant action is the medial rectus, adduction. And therefore, when the multiple sclerosis affects the MLF, the adduction gets affected. But usually both the MLF can get affected together. So they'll have internuclear ophthalmoplegia, bilateral INO, internuclear ophthalmoplegia, very characteristic of multiple sclerosis. But convergence may get spared because convergence has got a different area in the brain. So when we ask the person to abduct, the adduction is gone and there is nystagmus on the other side, which is known as abducting nystagmus. It is because of Herring's law of equal and dual innervation, wherein the brain tries to move the muscle. It is not able to move the diseased muscle, and therefore the muscle which has got an improper innervation because of the MLF, so there's an overcompensatory movement of the abducting muscle producing abducting nystagmus. Sometimes MLF and PPRF can get affected together, the paramedian pontine reticular formation, which results in 1.5 syndrome. Because the PPRF gets affected, one side movement is gone, half movement and half movement. That is, the eyes which are pulled towards its side is affected, and when the MLF gets affected, the adduction gets affected. The only movement possible is the half movement, and that too there is an abducting nystagmus, which is known as 1.5 syndrome, when the PPRF and MLF gets affected. So MLF gets affected characteristically in multiple sclerosis, which is known as internuclear ophthalmoplegia, and both the MLF can get affected, which is known as bilateral internuclear ophthalmoplegia. As I said, demyelinative disease and vascular disease, they present suddenly because the saltatory conduction is affected in multiple sclerosis, a myelinated nerve. So the presentation will be sudden onset of paraparesis, which we call as transverse myelitis. Person is already suddenly develops weakness, sensory deficits in a particular level below the spinal cord, and they are characteristically, they present as lesions which are disseminated in time and space. Disseminated in space, that means optic nerve can get affected in an area, and then spinal cord can get affected, which is totally different from the optic nerve. So they are disseminated in space, and then they are disseminated in time. They get an attack, they get better only to get the attack back again. So this is known as relapse and remission. So the characteristic presentation of multiple sclerosis is that they are disseminated in time and space. So they have varied presentations, various organs or various systems getting involved, and then there's a relapse and remission. They are disseminated in time and space. Then we have the Utas Phenomenon. A person wherein if he goes to a temperature where there is a higher temperature, to an area where there is higher temperature, the conduction velocity can again get affected, wherein the symptoms get again worsened, which is known as Utas Phenomenon. The diagnosis by MRI brain, where we see the characteristic plaques around the periventricular area. If the plaques are perpendicular to the ventricles, we call that as Dawson's fingers. We see MRI lesions, the plaque lesions in the spinal cord also, but they are of the limited area, unlike Neuromyelitis Optica NMO, where there are more than 3 non-contiguous areas gets affected. But here it is very limited area which gets affected in the spinal cord. So these will help us to diagnose, but in case we have doubt with clinical findings and still imaging, you can do cerebrospinal fluid analysis, lumbar puncture, the oligoclonal bands get elevated, and still if there is doubt, we can do VEP and BAER. If the BAER, the latencies get prolonged because of the involvement of the 8th cranial nerve, and in visual evoked potential, the latency gets affected because of the involvement of the 2nd nerve. These are known as evoked potentials, and evoked potentials get affected. The 2nd nerve, VEP, visual evoked potential, the 8th nerve, BAER, brainstem auditory evoked response. The treatment of multiple sclerosis is basically approached as acute treatment, the treatment for relapse, acute relapse, and then on a long-term basis we give disease modifying therapy. For relapse, when it is presented suddenly and it is an acute relapse, we give IV methylprednisolone about 1000 milligrams per day for 3 to 5 days, and then we slowly taper it by giving oral steroids. It is presumed to reduce inflammation. So we give IV methylprednisolone 1000 milligrams as an 1 hour infusion over 3 to 5 days, followed by, if necessary, a tapering dose of oral steroids. But very important is to prevent the recurrence of the relapse. So we give disease modifying therapy. The two very common and old treatment is, one is the interferon, second is the glatiramer acetate. The interferons block the invasion of T cells into the CNS by denying the access to the CNS through blood-brain barrier. Glatiramer acetate, we give it as a daily subcutaneous injection. They are well tested, they are old drugs, but then there's a good chance of relapse of about 30%. So then we give another drug which has come into force is the Dimethyl Fumarate. The advantage of dimethyl fumarate is that though it is of modest benefit, it can be given orally. And then we have the natalizumab, which is very, very effective. We give it as IV infusion. It also denies the entry of T cells into the brain. But the problem with the natalizumab is that though it is very effective, it can cause progressive multifocal leukoencephalopathy in persons who have the JC virus positive. But then it is very effective. 80% of the time it can cure the disease, whereas the interferons and glatiramer can only cure to the rate of 30%. Here it is about 80%, but then if the person has got JC virus positive, there is a chance of their developing progressive multifocal leukoencephalopathy. And then we have fingolimod, which also can be given orally, but then there's a chance of the herpes virus reactivation, so we have to be very careful. And then finally we have the teriflunomide, which is also very effective. And then we have the ocrelizumab, which is very effective in primary progressive multiple sclerosis. We've discussed so many drugs, but the drugs which are not very effective but time tested drugs are the interferon and glatiramer acetate. They are least effective. The moderately effective drug and which is frequently used is the dimethyl fumarate, because the advantage is that we can give orally. But then if the situation demands and we have to give an aggressive treatment, very effective treatment, then we can give natalizumab, but we have to be very careful. Only we can give in JC negative patients. This is about multiple sclerosis. Another disease which affects the myelin sheath is the neuromyelitis optica, but here the brain is not that much involved. The spinal cord is very much involved. More than 3 contiguous spaces gets affected, and in fact the cervical region also can get affected. They can have respiratory embarrassment. The optic nerve gets affected. They'll have severe visual loss. They'll have RAPD, relative afferent pupillary defect. And the treatment, these drugs are not much effective. We give treatment as the rituximab, which is effective, and of course the diagnosis by the aquaporin 4 antibody. The neuromyelitis optica can be diagnosed by aquaporin 4 antibody. The treatment is rituximab. The other demyelinating disease is the ADEM, which is a monophasic disorder, which is usually post-infectious and usually seen in children. These are all the important disorders of the myelin sheath of central origin which are acquired, known as demyelinating disorders. As I said in the early part of the discussion, sometimes the demyelinating sheath in the first place is not formed. The myelinating sheath is not formed in the first place, what we call as dysmyelinating disorder. So the dysmyelinating disorder, the myelinating sheath is not formed in the first place due to some biochemical abnormality, example metachromatic leukodystrophy, where there is a deficiency of aryl sulfatase, or it can be adrenal leukodystrophy, where the adrenal gland gets affected. They can have hyperpigmentation, leukodystrophy, cortex gets affected. Usually it's an X-linked, so it's seen in males, and very long chain fatty acids are increased. And usually the lesions are seen more in the parieto-occipital area. So these are the selective dysmyelinating disorders: metachromatic leukodystrophy, adenomyeloneuropathy, seen in children because they are dysmyelinative disorders. The demyelinating disorders are acquired disorders. The classic central demyelinative disorder is multiple sclerosis. The other disorders are the Neuromyelitis Optica and ADEM. I hope you have got a reasonable idea about the demyelinative disorders and you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.